Yes, Angela, and I think what we need to look at here is that the episode framework is really designed to be delivered just as it is now, except that we are designating a principal accountable provider, someone called the quarterback, and that person is someone who really is in overseeing the entire spectrum of care, and that we will hold them accountable for the outcomes and the total cost of care of that episode. More than just their fees that they give for that service, really they are going to be held accountable for the average cost of care for that kind of episode across all services that are given during that episode. So, for example, if you are the delivering doctor and you're an obstetrician, your obstetrician who is the PP, you can care of the patient for at least 8 weeks, and your episode of care that patient will encompass all of the costs for that pregnancy, and they'll average all those costs over time. So basically, we've designed the system. Everybody gets paid just like they are now, except you have one person who is accountable and will be at risk for high average cost episodes, but at the time put a gain share if they are effective and efficient with good outcomes and good quality metrics. So quality metrics done to basically say to folks that if we are going to give people bonuses for effective providers, we all want to make sure that are providing a quality product. So to ensure good quality, we have designed quality metrics for each episode. We're not expecting people to get A's or B pluses like we do with the hospital quality program, which is a pay-for-performance program, but rather we're expecting people to get at least a B minus, where they are showing that they are producing, on average, a quality product that certain national and local standards of care qualify for gain sharing. Now, sometimes this will mean that you have to put data into the portal. If you choose not to do the portal for the quality metrics, fine, except then you wouldn't be eligible for the gain sharing. Some of the quality metrics we're going to be doing as must pass, and others just tracking to see how well the system is performing. So here are the sequence. As I've said, everything is going just as we do today. Patients seek out and get care from their providers, be their PCP or the doctors who they are referred to, submitted for the service at the time of the service, and people paid for their services just like today. So straightforward, traditional fee-for-service care. We have at the end of a period of time, probably a year, well, actually the episode will last probably for acute care for like 60 days, about 30 days before and about 60 days afterwards. But at the end of the year, we can look at all the episodes of care attributed to a principal accountable provider. We look at the average cost of that episode of care and have more than 5 episodes. We weigh them against their peers delivering services to similar patients. We do some risk adjustments. We do eliminate outlier patients who extreme cost because of unusual events. We exclude some very high-risk patients with very significant and unusual comorbidities like sickle cell or cystic fibrosis. So we take the average cost per or them across the universe of providers, doctors, and hospitals in the state, and then look at thresholds to determine who potentially will be gaining and who will potentially be at risk. The key slide that demonstrates the different levels. If you're to the far left, you have a few physicians or providers that are at the very top, very high average cost per patient per episode. Above the acceptable line, folks are at risk for 50% of their average cost over the acceptable line, up to 10% of their total reimbursement from the payer. Now, this is not just 10% of their fees for service, but 10% of the total cost. Sorry, it's their fee for service, but it represents 50% of the total cost of care for that episode. It's going to be a small number of people. The next group between acceptable and commendable, those folks have delivered care, they've gotten their fee for service, they are at risk, nor are they particularly been efficient. So basically, they're in their year of service, they've got their fees, and that's the end of the story. Then you go to the commendable group, that's between commendable and gain sharing limit. Those have come in at efficient and effective average cost per episode, and so they share in the gain sharing. So, for example, if somebody in the middle of that slide found that their average cost per episode was, say, $200 less than the commendable limit, that meant that they would get $100 per episode bonus payment. If they took care of 20 patients and were $200 below the commendable line on average, they would get 100 times 20 or $2,000 bonus payment. Now, so that we have a gain sharing limit. So we determined that there probably is a point where it's very difficult, if not impossible, to deliver these episodes at a point of cost lower than a certain limit. So we have set a threshold where just in case someone does go below that, the gain sharing stops. There's a maximum amount of dollars per episode that you can benefit from gain sharing. And you would be in the commendable range. To get a bonus payment, you have to at least pass the threshold for the quality metrics as well. And the key thing here to realize is that 80% of the doctors or providers in this framework are revenue neutral or getting bonuses. There's a small percentage of physicians and providers are at risk. Who are at risk get report cards in advance before the episode, before the clock starts for measurement, and during the year they get quarterly report cards so they can track their progress. And it's possible that we can have gain sharing in the system with no one at risk to pay back. So and we are trying to shift the cost curve here. So most doctors and most providers, they're going to be revenue neutral or gain, and in fact, and in fact, the average physician probably does better under this system than in a program where we end up doing wholesale fee cuts to sustain budgets and to also reduce eligibility so there are more uninsured patients. So in ways, we think this benefits the system as well as it's beneficial to the average provider.